Sabia que mundialmente as cataratas congénitas são responsáveis por 5 a 20% das causas de cegueira em crianças? E em cerca de 3 a 4 em 10 mil recém-nascidos apresentam cataratas com perturbação da acuidade visual significativa? A avaliação destes casos é sempre um desafio, desde a cirurgia até ao próprio processo de reabilitação visual, necessário para prevenir ou reduzir a miopia. Quer saber mais sobre cataratas pediátricas? Sim? Então fique connosco. Mas prepare-se, o episódio de hoje será em inglês, pois temos um convidado estrangeiro que nos vai mostrar a sua perspectiva única sobre este tema. Este é o Ophthalmology GPS, onde navegamos com clareza pelo mundo da oftalmologia. Hello everyone and welcome to Ophthalmology GPS. I'm Cláudia Costa Ferreira, and in today's episode we will be talking about pediatric cataract management. I have here with me the coordinator of the Portuguese group of Pediatric Ophthalmology and Strabismus, Ana Vitescada, to guide us through this episode. Hello Ana and welcome to Ophthalmology GPS.
Hello, Claudia. Thank you for the invitation. So this is a very important topic, not only for pediatric ophthalmologists, but also for refractive surgeons and general ophthalmologists. I brought with me Dr. Nischal, who is the head of Pediatric Ophthalmology and Strabismus Department at UPMC Children's Hospital of Pittsburgh. He's a worldwide reference in pediatric cataract management, and he has even developed special techniques to tackle this entity. So thank you very much for having accepted our invitation.
Well, thank you for having me.
So I would start to ask you if every cataract needs to be operated on. So do you have any algorithm or do you have any threshold?
So I think it depends on the age of the child, how you assess a child. If you've got an older child, let's say who's 7 or 8, and they have a lamellar cataract, what I tend to do is do a glare test. So I shine some light, and if their vision drops by 2 lines or more, so they could be 20/20, 1-0, right? That's how you do it in Portugal. Yeah. But if you shine a light and they drop by 2 lines or more, it means that it's not safe for them to cross the road on a sunny day because they get glare. So that's one example. If you have a total cataract, obviously that's straightforward and you have to do something. Sometimes you'll have a partial cataract, like a central cataract. If it's on the posterior capsule, that's more troublesome. If it's on the anterior capsule, it can be less troublesome. And what I do for those cases is I use visual evoked potentials. And if the visual evoked potential gets a bifid wave, that's what we call it, it means the paramacular area of the retina is being stimulated, but not the central area. And that means the child will never see 20/20. They might see 20/40, 20/50. So the thing that you have to weigh up is the loss of accommodation for the gain of vision, distance and near, and the fact that they have to wear bifocals for the rest of their lives, So I think it depends on the type of cataract, the age, and the extent of the cataract, and the position as to how you decide if it's visually significant or not.
And when the cataract is visually significant, what is your preferred choice of surgery regarding the age of the patient?
Okay, I think that's an excellent question, but it's a difficult question to answer in a short way. So let me put it this way. I think that most unilateral cataracts at birth, congenital ones, I tend to leave aphakic because most unilateral cataracts are due to a form of PFV, persistent fetal vasculature. So I tend to leave those aphakic. If they're bilateral cataracts and the capsular bag diameter, and that is the distance. So I use linear ultrasound. I've never used vector ultrasound since 1999. Linear ultrasound allows you to see the lens, and you measure the equator to equator at 1 millimeter. As long as it's greater than 8 millimeters, it's okay. You're going to be able to put a foldable lens in the bag safely. So I look at the size of the eye, the size of the capsular bag. I'm not so bothered about the cornea. So if I have a cornea of 9 millimeters, even 8.5 millimeters, as long as the capsular bag is a normal size, I will put an implant in. Now, in bilateral cases, you can afford to wait a little bit longer. Maybe if they're total, maximum I wait is 11 to 12 weeks, maximum. But if they're partial and they're getting worse, you can often wait till about 4 months and then do bilateral with implantation. Now, people get very worried because they say, oh, you're implanting an infant. Yes, but you have to choose the eye carefully. You can't implant every infant. I prefer to implant infants because if the parents can't afford contact lenses or the child goes through a phase where they don't want to wear glasses, they don't want to wear contact lenses, they have some correction. But the technique is so important. It is so important. And, you know, I tell my trainees, adult cataract surgery is fun. Pediatric cataract surgery is stressful. Right? It only becomes fun when they've reached 8 and they've got good vision because you've got so much rehabilitation to do. So the technique matters. You know, the anterior rhexis has to be precise. I use the 2-incision push-pull rhexis that I devised, 1998. Well, oh gosh, I feel old. 1998. I do a posterior rhexis in the posterior capsule as well. The vitrectomy technique is very important. You must do the vitrectomy underneath the posterior capsule as well as in the middle. And you must also, I'm sorry, is that mine? I apologize. So it's very important when you do the vitrectomy that not only do you do it in the center, but underneath, and then you polish the capsule. Polishing the capsule is essential because if you polish it, then you get rid of the lens epithelial cells because those are the things that grow across. And I don't think residents get taught to polish the capsule, even in adult surgery. And I think that's so important. Because, you know, I remember as a resident, I was so glad that I didn't drop the nucleus. I just want to finish and put the implant in. But that's the time that we have to teach them, polish the capsule, get rid of as many lens epithelial cells as you can. And then the last thing is I've begun to do more and more optic capture. I think that's really helpful to allow the anterior and posterior leaves of the capsule to fuse. Then the lens epithelial cells don't grow across and you don't expose the immature trabecular meshwork to lens epithelial cells, which can cause open-angle glaucoma.
So, Dr. Ken, Nischal, what is your rationale regarding intraocular lens implant?
In terms of, what do you mean, for refraction?
Primarily or secondary implant, you have already told us.
Yeah.
The power of the lens,
Oh, okay.
how do you choose, and what type of IOL do you prefer?
Okay. So I have a very simple rule in my life. And my rule is I want to do whatever I want to do for difficult cases in the easy cases. So when I do the difficult cases, I don't have to think. It's automatic what I'm going to do. So I like to use a 3-piece hydrophobic acrylic lens. Why? Imagine that you have entered the eye, and as you enter the eye, the posterior capsule ruptures. If you have a 1-piece lens, you have to take that out and then use a 3-piece lens to put in the sulcus. But if you already have a 3-piece lens, you just put it in the sulcus, right?
Right.
Equally, if you are operating and something happens to your anterior opening and it ruptures, now you can do optic capture with the 3-piece lens. So I do not understand what the benefit is of using a 1-piece lens when the 3-piece lens can be used in all the complicated cases. It doesn't make any sense to me. But everybody has their own preferred way. So it's not to me to tell anyone that my way is better, but I'm more comfortable doing it that way, my way. So the lens power, I use the Hoffer-Q equation for short eyes, 20 or less, and SRKT for the longer eyes. Now, Hoffa Q does not have an A constant. It has an ACD. And that ACD is calculated for adults. So when I do any child, forget about infants, let's say I'm doing a 1-year-old, I measure the anterior chamber depth on the table and I add 1 millimeter, right? And when you do that, you customize the ACD. And since I've been doing that, I've been getting accurate post-operative refractions.
Amazing.
And I think sometimes I come to meetings and I say something and people go, really? And I go, okay, I'm going to publish that now. So yeah, I do that for Hoffa Q. Now, I do, if the child is under 3 months, I aim for a +10. 3 months to 6 months, +9. 6 months to a year, +8. And then I go right down. At 12, I will go for emetropia. But before then, it's between 10 and 12, it's +0.5. Look, the most important thing is an understanding of emetropization. And with all the myopia control that's going on, right? We now understand that it's the peripheral retina that drives axial growth. When you look at pictures of children who have white fibrotic capsules, what do you think is happening to the overall contrast in that eye? It's reduced. And those are the eyes that get myopic shift. So lens polishing is essential because you don't get that change from a epithelial cell to a fibroblast. Because that's why they go white, right? That's why you get phimosis. If you get rid of the lens epithelial cells, it doesn't happen, or it happens less. And that's why I think in my hands, I don't see the big myopic shift that people have reported.
Amazing.
Do you think that visual access, opacification, and secondary glaucoma are major threats for pediatric cataract surgery? And do you have any tips for avoiding or mitigate them?
So, again, an excellent question. How can I? Okay, so I have to organize my thoughts a little bit. So the first question is visual access opacification, but I think I've explained how I mitigate that, right? I do the vitrectomy in a certain way, I do lens polishing in a certain way, and also I give intracameral preservative-free dexamethasone 2 milligrams into the anterior chamber. And I think that really helps because you don't get any anterior membranes, which can be a problem. As far as the glaucoma is concerned, I get the last glaucoma I had in a pseudophakic lens was in 2014, and it was a 4-year-old, unilateral, but posterior lenticonus, which is why I put the implant in. I don't see that much glaucoma in pseudophakia, but I do see it in aphakia. Now, in aphakia, the ones I see are often PFV cases. And I think this has been published. David Walton published this. If you look at an eye that has aphakic glaucoma, look at the edge of the pupil. And if you're getting an ectropion UVE, right, look carefully on the iris surface. You'll see these fine blood vessels. Look in the angle, and there is a kind of like a fibrovascular pannus in the angle.
It will close.
I do a goniotomy, and it treats it. So sometimes, if I see a child with a PFV where, sometimes when you do a PFV eye, you have to take the iris because if you leave the iris, the pupil the same size, it closes down, right? So sometimes I have to cut that pupil open. When I do that, I will do a prophylactic goniotomy at the same time.
To finish, I would just ask you very briefly your 3 major tips to having a successful, uncomplicated cataract surgery for a pediatric patient.
Number 1, before you do a pediatric cataract, practice on animal eyes. You must practice. The pig eye is very good for your capsulorhexis. It's very similar to a child, number one. Number two, each step is essential. First step goes wrong, the second one will go wrong, and the third one will go wrong. And the third thing is, don't panic, right? I tell my fellows, no Harry Potter maneuvers. You know Harry Potter, the magician,
of course.
with the wand? They're in the eye and they're doing this. No, everything has got to be slow. All the movements have got to be slow, and they have to be from the wrist, not from the elbow.
Wonderful. Amazing tips. So we follow now to our next segment, that is InFocus. So Dr. Nischal, what do you bring us today? Any novelty or hot topic that you think that is worth to share with us?
Well, it's got to be myopia, hasn't it?
Okay.
I mean,
It's
it's
a
got
hot
to be
topic,
myopia.
of course.
And I think what is fascinating is what I've learned is doctors don't read literature very well. We're terrible. We read abstracts. We
True.
don't read papers. You know, there has been this huge thing about atropine, low-dose atropine, 0.01%, 0.02%, 0.05%. But nobody has sat back. And then in America, 0.01% doesn't work. They published that, right? The PD
Yeah.
group. And nobody sat back and thought, wait a minute, what is going on here, right? Let me give you an example. If you look at public health policy for antenatal care, right? In developed countries, they have been giving vitamin A to women who need it in their antenatal care to reduce fetal deformities, you know, including ocular coloboma, microphthalmos. Imagine you do a study where you give everybody vitamin A, everybody, doesn't matter who it is, and you're giving it in a country where they already are giving vitamin A where it's needed, right? You will not see a change in the rate of deformities. It'll stay the same. But if you give it in a country where there is no antenatal care, suddenly the rate of microphthalmia or
Falls.
congenital deformities will fall.
Worse.
And people will say, well, vitamin A doesn't work in the developed countries. We wouldn't say that, right? So this is the thing that's happened with atropine. In Singapore and Taiwan, they started public health school policy in 2000, where children had to go outside for 2 hours. They weren't allowed to read for more than 30 minutes. They had to take a break. And it was at the school level, right? In China, they did this study, brilliant study. They have this thing called WeChat, right? Instead of WhatsApp. And they had, in the same school, a group of parents who got a WeChat message on a Friday and a group who didn't. And the group who got the message said, make sure your children play outside. Don't let them read too much. No digital stuff. Guess what? In 6 months, the group that got the message, their myopia progression dropped. The group who got no message, it carried on continuing at the same rate. So now if you accept that school health policy can make a difference, in Hong Kong, there was no policy till 2019. So when they did the LAMP study, right, they said 0.05 is better because there was no public behavioral health policy. It's like saying, I'm going to use Ozempic to lose weight, but I'm still going to have 20 hamburgers every day. It ain't going to work. So we have to think about behavior and then think about the interventions.
Okay.
The optical interventions are amazing. I mean, really, they are a game changer. I don't know if you wear glasses, but I remember when I got my glasses, I was 11, and then every 6 months they would make them stronger and stronger. And we only now realize that in the normal concave lens, the peripheral retina goes into hyperopic defocus. In other words, the light falls behind the retina, and so the retina goes, aha, I got to grow faster to catch it. But these lenses that give you myopic defocus, they work very well. So I genuinely believe that there is enough evidence that we should prevent axial elongation causing myopia in children, and it should be a joint effort between optometrists and ophthalmologists. And we need governments to get involved. We need public health policy at a school level.
Very good. Yeah.
Thank you very much, Dr. Nischal. I thank you for the generosity that you took your time to be here, sharing all your knowledge and all your tips, like now in the InFocus news with us. This has been an amazing voyage with you and with Claudia. Thank you, Claudia, for having me
Thank you.
again in an episode. This was wonderful.
Amazing.
And one more episode of Ophthalmology PS.
Thank you, Anna, and thank you, Dr. Nischal, for this amazing episode.
No, thank you so much for inviting me.
E assim chegamos ao fim de mais um episódio. Relembro-vos que ele estará disponível nas plataformas habituais, no site da SPO, no Spotify, YouTube, Apple Podcast. Subscrevam o nosso programa e deixem a vossa opinião. Este foi mais um Oftalmo GPS, onde navegamos com clareza pelo mundo da oftalmologia. Até breve.